Could the medication you take to, you know, clear up a severe rash or maybe calm your asthma be the hidden reason you leak when you sneeze?
It sounds like a pretty massive stretch.
It really does. But today, we are looking at a truly fascinating medical puzzle for this deep dive. You take a powerful corticosteroid for dangerous inflammation, the inflammation goes down, and, well, you assume the story ends right there.
Yeah, and it's very tempting to view medicine through that lens of simple cause and effect. You have a fire, you spray the fire extinguisher, and the fire's gone.
Right.
But human biology is rarely a straight line.
Which is exactly why we're digging into all this today.
Right.
We want to figure out if there is this hidden web of side effects that we just aren't paying enough attention to.
And it's a very complex web.
It is. So our specific mission today is to uncover if high-dose systemic corticosteroids can cause the kind of connective tissue weakening that directly exacerbates stress urinary incontinence, or SUI. Essentially, we want to know if the drug sealing your lungs is secretly dismantling your pelvic floor.
To answer that, we really have to look past the targeted inflammation. We have to examine what these systemic drugs are actually doing to the cellular instructions being broadcast to, well, almost every tissue in your body.
And we've got an amazing stack of sources for you today. We're pulling from human clinical trials, cellular biology studies, and even veterinary science on endocrinology.
It's a fascinating cross-section of data.
Yeah. But to make sense of how a steroid could cause a leak, I feel like we first need to rethink how the bladder actually works. Because I'll admit, before preparing for this deep dive, I pictured the whole system like a water balloon.
Like a water balloon with a single valve at the bottom.
Exactly. If the valve gets a little loose, a sneeze forces a drop of water out. Simple mechanics.
Yeah, that is probably the most common misconception out there. The biological reality is vastly more complex.
So it's not just a single valve pinching shut.
No, not at all. When we look at the clinical literature regarding female urinary continence, there are two primary frameworks that dominate the conversation. We have the hammock hypothesis and the integral theory.
Okay.
And both of them completely reject the idea of a single isolated valve doing all the heavy lifting.
So if it's not just a single valve pinching shut, how does the body actually stop urine from escaping when, say, a sudden physical force hits it?
Well, it relies on a highly coordinated team effort. Think about the sudden, intense downward pressure of a sneeze, or maybe a heavy lift at the gym.
Right, a lot of G-force.
Exactly. To keep the urethra closed under that sudden G-force, your body relies on a combined system of pelvic fascia, ligaments, the anterior vaginal wall, and surrounding connective tissue.
That's a lot of moving parts.
It is. And all of these structures rest upon what we call a viscoelastic matrix, specifically the extracellular matrix, or ECM.
Viscoelastic, meaning it has to be, what, flexible enough to absorb a shock, but firm enough to hold its shape.
Precisely the balance required. This matrix is heavily fortified with collagen, elastin fibers, and proteoglycans. It's not static. It's a living, dynamic scaffolding.
Wow.
The mechanical stability of the entire genitourinary tract depends on this connective tissue remaining intact. If that tissue becomes defective, the surrounding structures relax, the hammock basically sags, and the urethra can no longer properly compress.
So that makes connective tissue the absolute star of the show here.
Without a doubt.
But, digging into the clinical studies on women who actually suffer from stress urinary incontinence, the data on their collagen levels seemed really contradictory at first glance.
Oh, it can be highly confusing if you only look at the surface level metrics.
Right, because I was reading that they took biopsies, right?
Yes. For instance, if researchers take a biopsy of the endopelvic fascia from women with SUI and compare it to continent women, some studies show absolutely no significant reduction in the overall raw quantity of collagen types I and III.
So if you just put the collagen on a microscopic scale, they weigh the exact same.
Exactly. They weigh the same.
Which would initially suggest that collagen isn't the problem at all. If you have the same amount, it should work the same, right?
That was the debate for quite some time. But then researchers changed their methodology. Instead of just weighing the dead tissue, they took skin and fascia biopsies from SUI patients and isolated their fibroblasts.
Fibroblasts. Those are the specialized cells that act like tiny biological factories,
Yeah,
right?
yeah.
The ones that manufacture the collagen.
You've got it. They grew these cells in a culture to actually watch them work in real time.
And that's where the deficit showed up.
It was a dramatic difference. The fibroblast cultures from the SUI patients accumulated 30% less collagen than the cultures from the continent women.
Wow, 30%, that's massive.
It is. And on top of that, when they examined the periurethral tissue under an electron microscope, they found that the collagen fibrils in SUI patients were irregularly organized.
Meaning what, exactly?
They looked chaotic compared to healthy tissue. It wasn't a neat, strong weave.
Wait, okay, let's walk through how that actually works in practice for you, the listener, living with a pelvic floor. Because if the total weight of the collagen is the same, but the cells are producing 30% less, and it looks chaotic under a microscope, it really makes me think of a trampoline.
Go on. I like that analogy.
So it's not that your trampoline is missing half of its springs. If you went around and counted them, the raw quantity might still be there.
Right.
But the springs that are there are rusted, they're warped, they've been stretched totally out of shape, and they lack the tensile strength to actually bounce back when you jump on it. So the total weight of the metal is identical, but the structural integrity is just completely compromised.
That is a highly accurate way to visualize it. It's really not about the raw mass of collagen present at any arbitrary moment.
That's about the quality.
Exactly. It's about the ongoing relentless repair process. Your fibroblasts need to be constantly weaving new, strong collagen fibers and clearing out the damaged ones for that trampoline to hold up under physical stress. Tensile strength is everything.
Which brings us to the core of our deep dive today. We know a weak trampoline leads to stress leaking. So what happens to those hardworking fibroblast factories when we flood the body with high-dose systemic corticosteroids?
We observe a profound systemic shutdown of that repair process.
A total shutdown.
Almost total, yes. There is a human skin study that perfectly illustrates this mechanism. Researchers tracked patients who were taking systemic prednisone. And we aren't talking about a massive experimental dose here.
Right.
This is a clinical dose of just 0.48 milligrams per kilogram per day.
Which is a fairly standard prescription, right? Like for managing an autoimmune flare-up or severe asthma.
Very standard. So to measure what the drug was doing, the researchers tracked the concentration of procollagen propeptides in the patient's skin.
Okay, I definitely need a translation for procollagen propeptides.
Hmm.
Are they just counting the new collagen fibers?
Not exactly. Counting new collagen directly inside living tissue is incredibly difficult to do accurately. So they look for the chemical byproducts of construction instead.
Oh, I see.
Imagine you're buying new furniture for an office building. The procollagen propeptides are like the large cardboard boxes the furniture arrives in.
Okay.
The cells build the collagen, unpack it to use in the tissue, and then throw the chemical wrappers away. By counting those discarded wrappers, researchers can determine exactly how much new collagen is being manufactured.
That makes perfect sense. So what happened to the number of wrappers when the patient started taking the prednisone?
The concentration plummeted to merely 20% of the normal control values.
20%. That is an 80% drop in production, just from a standard clinical dose.
Yes. The researchers concluded that the drug almost completely abolished new collagen synthesis in the skin.
That is wild.
It is. And we see this devastating effect replicated across entirely different biological models, too. To understand how deep this shutdown goes, we can look at a study involving chick embryos.
Chick embryos?
Yes, they were exposed to dexamethasone, which is another very potent corticosteroid.
Oh, right. I remember this one from the reading. This proved the shutdown wasn't just a chemical delay, right? It was happening at the genetic level.
It's a fundamental intercept. The dexamethasone significantly reduced the actual messenger RNA, the mRNA, that carries the genetic instructions telling the cells to manufacture procollagen.
Wow. So if we go back to the factory analogy, the steroid isn't just barricading the doors so the workers can't get materials.
No.
It is literally intercepting the architectural blueprints before they even reach the factory floor. The fibroblasts don't even know they're supposed to be building anything.
The cellular programming is completely rewritten, but stopping new construction is really only half of the mechanical problem.
Oh, no.
Yeah. To see the physical consequences of this cellular shutdown, researchers conducted a mechanical test on isolated rat tail collagen fascicles.
Okay, I have to ask, I assume they use rat tails because the tendons are long, uniform, and easy to isolate.
That is correct. They are absolutely ideal for mechanical stress tests.
Got it.
In this study, they took these tiny microscopic strands of collagen, incubated them in methylprednisolone, and then subjected them to a displacement to failure test.
A displacement to failure test. So they hook the microscopic fiber up to a machine and literally stretch it until it snaps.
They do. It measures the exact amount of force required to achieve structural failure. And the timeline of the results is what makes this so critical.
How fast did it happen?
After just 3 days, and again at 7 days of exposure to the steroid, the physical tensile strength of those collagen fibers was significantly lower than the control fibers that hadn't been exposed.
Wait, let me make sure I'm wrapping my head around this. The steroid isn't just stopping new collagen from being built.
Right.
It is actively making the existing fibers physically weaker and more prone to snapping under tension.
That is the direct mechanical consequence. It's actually the reason sports medicine doctors are incredibly cautious about injecting corticosteroids directly into a structurally load-bearing area, like an Achilles tendon.
Oh, because it weakens it.
Exactly. The drug can weaken the specific regions of the tendon, leaving the individual collagen fascicles brittle and highly vulnerable to rupture under the sudden stress of, say, a jump or a sprint.
Taking this back to the pelvic floor, that is just a terrifying combination.
Yeah.
Because the hammock hypothesis relies entirely on the tensile strength of that extracellular matrix.
Correct.
So if a systemic steroid is wiping out 80% of new collagen production and simultaneously reducing the tensile strength of the cables that are currently holding the hammock up, I mean, mechanical failure feels completely inevitable.
Under sudden stress, the tissue simply cannot absorb the force. However, and this is a big however, biology is rarely a monolith.
Right.
Before we conclude that corticosteroids unilaterally destroy all connective tissue everywhere, we have to examine a glaring exception in the data that complicates our theory.
Yes, the HESM cell. I actually had to read that section of the research twice because it felt like a typo.
It is a fascinating biological wrinkle. HESM stands for human intestinal smooth muscle cells. We've established that corticosteroids notoriously inhibit collagen synthesis in fibroblasts, the primary builders in our skin, tendons, and pelvic floors.
Right, the 80% drop.
But when researchers applied dexamethasone to subconfluent cultures of these intestinal smooth muscle cells, they observed the exact opposite reaction.
Just to clarify for everyone, subconfluent just means the cells are still actively growing and dividing in the petri dish, right? Like they haven't run out of room yet.
Exactly. They're in a highly active state. And in that active state in the gut, the steroid actually increased pro-collagen secretion by a staggering 60%.
60%. Why on earth would the body shut down repair in the pelvic floor, but send the construction crews into absolute overdrive in the intestines?
It perfectly illustrates that a drug does not have one uniform magical effect across the entire body. The response is dictated by the highly tissue-specific receptors and the internal programming of that specific cell type.
So it's context dependent.
Very much so. The gut has a very different physiological mandate during a high-stress, high-cortisol event than the skin or the fascia does.
Okay, so while the intestinal cells are hoarding all the new collagen, the fibroblasts in the pelvic floor are essentially starving.
Yes.
But as I kept reading the source material, I realized the situation for the pelvic floor is actually worse than just starvation. There is a whole secondary mechanism at play here involving tissue degradation.
The degradation debate is critical here. To fully grasp this, we have to rewind to a pivotal 1977 study on human keloids.
Keloids are those thick, raised, overgrown scars that extend way beyond the original injury, right?
They are, and dermatologists frequently treat them by injecting a steroid, like triamcinolone, directly into the lesion.
Because logically, if steroids block the mRNA blueprints and stop collagen synthesis like we just talked about, injecting a steroid into an overgrown collagen scar should stop it from growing.
That was the prevailing assumption for a very long time. And clinically, it works. The injections do cause the keloids to soften and shrink.
Okay, so what's the issue?
Well, the 1977 researchers decided to actually measure the biochemical output of those shrinking scars. And what they found completely disrupted the accepted logic. The steroids did not lower the naturally high rate of collagen synthesis in those specific keloid cells.
Wait, what? So the fibroblast factories inside the scar were still pumping out collagen at maximum speed, completely ignoring the steroid, but the scar was shrinking anyway.
Yes.
How is that physically possible?
It pointed to a hidden variable. If you are constantly adding new bricks to a wall, but the wall is getting smaller, well, there's only one logical explanation. Someone else is removing the old bricks faster than you can lay the new ones.
A demolition crew.
Exactly. This led researchers to a massive realization about how these drugs function. Corticosteroids don't just put a pause on collagen production in vulnerable tissues. They likely actively enhance enzymatic degradation.
Meaning what, chemically?
They upregulate the enzymes responsible for breaking down the extracellular matrix.
Okay, let's put all of this together for the fibroblasts in our pelvic floor. because this is intense.
Go for it.
If you are taking a high-dose systemic steroid for a severe asthma attack, your pelvic floor isn't just dealing with a paused repair cycle. It is getting hit with a biological double whammy.
Yes.
The drug is burning the blueprints so no new scaffolding can be built, while simultaneously sending in a demolition crew to actively dismantle the existing scaffolding.
The net result of those two compounding factors is a rapid, aggressive loss of structural integrity in the tissue.
It makes you wince when you think about the physical forces the pelvic floor has to withstand on a daily basis while all of this microscopic demolition is happening.
It's a lot of strain.
But obviously, we can't exactly run a trial where we give healthy women massive doses of steroids just to see if they start leaking urine. It's totally unethical.
Very unethical.
So to find the ultimate macro-level proof of this mechanism, we have to look outside of human trials entirely.
We have to look to veterinary science, specifically a condition known as Cushing's syndrome or hyperadrenocorticism.
Cushing's is basically what happens when the body's internal steroid production goes completely haywire, right?
It is the pathological overproduction of cortisol, which is the body's natural endogenous glucocorticoid.
Okay.
When a dog or a cat develops Cushing's syndrome, usually due to a pituitary or adrenal tumor, they aren't just getting a temporary prescription pill. They are subjected to a constant, inescapable endogenous barrage of steroids, day after day.
It's the ultimate worst-case scenario for connective tissue.
It really provides a devastatingly clear window into what chronic steroid overload does to mammalian scaffolding. The physical symptoms these animals develop directly mirror every single cellular mechanism we've discussed today.
Wow.
Take, for example, the classic presentation of a dog with Cushing's. They develop a very distinct, pendulous, pot-bellied appearance.
See, my immediate assumption would be that the dog is just retaining fluid or gaining a massive amount of fat from all the hormones.
Many pet owners assume the exact same thing, but the reality is much more mechanical. The pot-belly is primarily the result of profound abdominal muscle wasting.
Muscle wasting.
Yes. The relentless cortisol is breaking down the protein and the connective tissue fascia that holds the abdominal wall tight. The hammock is failing.
Oh, I see.
The scaffolding loses its tensile strength, and the internal organs simply push the weakened muscle outward.
The tissue literally can't hold the organs in place anymore. That is incredibly sad. And the effect on the skin is just as extreme, right? Cats with Cushing's experience skin thinning so severe, so fragile, that it can spontaneously tear just from the animal being picked up or groaning itself.
Because the collagen matrix that gives skin its leather-like durability has been almost completely degraded.
There was also a bizarre detail in the sources about their ears. The tips of their ears can peculiarly curl inwards.
Yes.
Because the structural matrix that normally holds the cartilage flat and rigid is just melting away. But the absolute clincher for me, the symptom that permanently tied this entire deep dive together, was the urinary function.
Dogs with Cushing's invariably exhibit polydipsia, which is extreme water consumption driven by the endocrine imbalance. But crucially, they also exhibit severe urinary incontinence.
They leak.
They leak constantly, their bladders are full, and the structural integrity of the pelvic hammock, the exact viscoelastic matrix we discussed at the beginning, is so fundamentally compromised by the cortisol that the urethral sphincter mechanism simply gives way.
It is the ultimate validation of the theory. If an animal's natural overproduction of cortisol can cause their abdominal walls to physically degrade, thin their skin until it tears, and lead directly to urinary incontinence,
Yes.
it makes perfect biological sense that a human taking high-dose synthetic corticosteroids could experience that exact same pelvic floor weakening.
The through line is undeniable at this point. If we synthesize the disparate fields of study we've explored today, we know the female continence system relies on a collagen-rich matrix to maintain the tensile strength required to compress the urethra. We know from cellular biopsies and genetic markers that high-dose systemic corticosteroids drastically inhibit new fibroblast collagen production.
They intercept the blueprints.
They intercept the blueprints. We know from mechanical stress tests that they physically reduce the tensile strength of existing fibers.
The rusting springs.
Exactly. We know from keloid studies that they likely accelerate the enzymatic degradation of the tissue. And finally, we see the tragic macro-level result of this exact process in the muscle wasting and incontinence of animals with Cushing's syndrome.
So the answer to our mission today is a definitive yes. These anti-inflammatory drugs, while absolutely necessary for treating severe acute conditions, absolutely have the potential to exacerbate stress leaking by quietly dismantling the connective tissue.
It is a critical, often overlooked systemic consequence that anyone managing long-term or high-dose treatments really should be aware of.
It really changes how you look at a prescription bottle.
Yeah.
Because our bodies are not static objects, They're constantly sustaining microscopic wear and tear from everyday life. A persistent cough, a bad bout of allergies, carrying heavy groceries up a flight of stairs. If high-dose steroids shut down the biological repair crew that normally fixes those tiny daily micro-tears in our pelvic floor, what happens to those injuries? Do they just accumulate permanently while we are on the medication?
It's a very sobering question.
Next time you're reading the side effects of a systemic drug, it's worth asking yourself, what is this doing to my invisible scaffolding?
An essential perspective for truly understanding our health.
Thank you so much for joining us on this deep dive. Keep questioning the unseen connections in your own body, and we will catch you next time.